Good afternoon and welcome to the National Action Alliance to Advance Patient Safety Summer Webinar Series. We're delighted that you could be with us this afternoon. Just to let you know, this call is being recorded for replay. Currently, all lines are muted. If you are a speaker, just a reminder to keep your line muted when not speaking and unmute yourself when it is your turn. A couple of minor logistics. We're requesting your active participation in today's call. At different points during the agenda, we will turn to you to hear directly from you regarding some effective questions. So please feel free to use the chat function or to raise your hand so that we can open up your line and hear from you directly. With that said, Dr. Valdez, the floor is yours. Next slide, please.
Good afternoon, everyone. I'm Robert Valdez. I'm the Director of the Agency for Healthcare Research and Quality, and I'm joined by patient and family advocate and President of Consumers Advancing Patient Safety, Mrs. Helen Haskell. Helen?
Helen, if you could unmute yourself.
Oh, I apologize. Thank you, Dr. Valdez. I am so pleased to be here and I welcome everybody. So glad to see you all.
Thank you very much, Helen. And on behalf of Secretary Becerra and all of the Health and Human Services team, Helen and I would like to welcome you to the first of the HHS Summer Webinar Series for the National Action Alliance to Advance Patient Safety. And also on today's call, we have about a little over 250 participants who represent healthcare systems, skilled nursing facilities, hospitals, academic institutions, air medical transport companies, and patients, of course, and their families, and as well as other clinicians. I want to thank you, first of all, for the work that you do to heal and keep safe our patients every day. Helen?
And I also want to echo Dr. Valdez. Thank you for all you do, especially our frontline workforce and all the patients and families and patient advocates who've all rolled with the punches and done so much to keep things going during these past trying few years. Thank you.
Next slide, please. Today we have 4 goals. We're going to review the National Action Alliance for to Advance Patient Safety, remind everybody why there's such an urgency to focus on patient and workforce safety today in the wake of the waves of the pandemic, to report to you about the experiences that that people have experienced emerging from the pandemic and needs that we've learned about through the information efforts that we've taken advantage of gathering over the course of the last few months. And lastly, to provide an overview of the National Action Plan and to hear from 2 organizations using elements of the National Action Plan, the self-assessment tool, and also to reinforce the importance of organizational governance that is so important in maintaining a safety-oriented organizational culture. Next slide, please. Just by way of reminder, the Secretary believes that the Action Alliance gives us the best chance to make sure HHS is using all of its tools to work with stakeholders most effectively, because we believe we can give people a sense that when walked through the doors of that medical service facility, doctor's office, hospital, urgent care center, that they're going to walk out in better health. The Secretary established a department-wide initiative to work with health systems, patients, and families, and others to co-create this National Action Alliance on Patient and Workforce Safety. Next slide, please. You can find out more information and find best practices and tools that AHRQ and others have put together at this website. And you can also sign up to get updates on the work of the Action Alliance. I encourage everyone to join if you haven't joined already. And it's really about creating this living and learning community that shares evidence of best practices and also takes advantage of our peer-to-peer learning opportunity. Next slide, please. Some people think that patient safety really hasn't is an impossible thing to do. Reaching that zero error, zero event world. But I think some evidence shows that over the course of the last couple of decades, we've shown at least if in a few areas where we've made some really focused attention, we've had slow but steady progress. In many other areas, however, we haven't shown that kind of safety progress at all. And it's that situation that leads to what we see in a recent study. Next slide, please. In Massachusetts, despite those limited improvements, safety issues persist. 24% of admissions experience some kind of adverse event. That's 1 in 4 people admitted experience something. And during the pandemic, we have some indications that perhaps the situation worsened. And we know that the challenges to do patient safety remain enormous because of workforce burnout, because of the increased complexity of patient care, and really the difficulty it's been to share best practices across our communities of service. Next slide, please. As we've shown in our National Healthcare Quality and Disparities Report for the last 20 years, what we've been doing largely hasn't worked. So we need to start thinking and doing things differently, because healthcare is not safe until it's safe for all. And what we've demonstrated is that in racial and ethnic communities, particularly African American and American Indian communities and Hispanic communities, the quality of care is and the safety of care is not of equal levels as in the majority population. Misdiagnosis, overdiagnosis, and poor treatment and management contribute to unsafe practices and quality inequities. Next slide, please. I just want to ask, did this data ring true for you in your own personal observations? Is this what you're seeing in your own facilities and your own settings? We'd like to talk to you more about this as this webinar moves on. Let me tell you a little bit.
I'm
Yes.
sorry. Dr. Valdez, we've placed the question into the chat and would kindly ask folks to answer the question. And also, while we're waiting for folks to answer, we can receive some feedback. I wonder if Helen might comment on her key takeaways from this data.
Yes, thank you. Thank you so much. And thank you for that excellent overview, Dr. Valdez. I have a lot to say about these numbers. I'll just make a few comments. The first is about the unevenness of patient harm. Equity is much larger than racial and ethnic status. People are biased against because of all sorts of things, their medical conditions, their body type, their economic and educational status, their gender. Sometimes people believe these biases are medically sanctioned. This is beginning to get examined, but it's one of the things we need to look at. It needs a lot more examination. But much more important, I think, even more important, is the subtext in all these figures, which is that we don't know all we need to know about the causes of patient harm. Before the pandemic, I measured patient safety events had declined, but patient harm had not. After the pandemic, everything seems to have declined, which indicates to me that patient safety doesn't really occupy the prominent place it should have in the minds of healthcare providers. And healthcare without safety is not really healthcare. If we're going to take care of people, patient safety needs to be embedded foremost in the minds of healthcare providers and patients alike. The fact that harm in known areas had declined means that we know what to do about a lot of these problems, even if it's not always done. But as we learn to deal with some of these risks, new ones emerge. And I think that's something that has not always been acted upon in patient safety. We need to stay on our toes. We need to be sure that the Action Alliance is focused on learning, and not just on learning, but putting that learning into practice so that things don't get lost in the vast middle between policy and practice. This means focusing on the crucial but really delicate interaction between patient and provider. Preparing, supporting, informing, and empowering both patients and frontline providers means recognizing that they're going to be your most important sources of learning, and truly, especially listening to patients who see more of the healthcare system than anyone else. And finally, I'll say this, and I hope I haven't been preaching too much, but I am a patient safety advocate. I talk every day to patients who have been harmed, and I see all too many circumstances where health systems blind themselves by elevating avoidance of liability over learning how to be safer. And if you want to know why there is mistrust, and there's a lot of hand-wringing over the concept of mistrust of healthcare, but this is a major reason. If you prioritize learning, you'll save money in the end. You and your patients will be safer, and you will have the satisfaction of a job well done. The key is keeping to the mission of keeping patients safe. And that's it from me. Thank you. Thank you for listening.
Thank you, Helen.
Thank you, Helen. I can't agree with you more that that the issue of trust is at the base, and unfortunately the misinformation has further eroded the trust that the public has in our local healthcare systems and in our healthcare providers. We see it both in the increased violence that we see against our colleagues, as well as it's really a mistrust of the advice that we offer in the care that's being provided. And I think you're absolutely right that we have to keep that in mind as we organize and deliver services, and keep that as really one of our goals, is to regain the trust of our patients and our communities.
Well,
May I have the next-
to add, I think that people need to believe that their healthcare providers care, and they don't believe that often now, and that's something that providers need to think about and work on.
Thanks, Helen. May I have the next slide, please? I just wanted to let you know that this is the timeline as we've begun to try to develop this National Action Alliance. As I said, Secretary Becerra in November really staged a call for action. We sent out a request for informations in January. The National Advisory Committee of the Agency for Healthcare Research and Quality took on this work to begin to look at some of the responses, and also call for an ongoing subcommittee of the NAC to help guide us as we begin to launch this effort with you nationally. This soft launch of the summer webinar series starts today and will take place through the end of the summer in September. And we hope to in the fall launch a full-blown National Action Alliance with being responsive to your needs and to your requests. Next slide, please. The next webinars are scheduled for April, June, July, and August, and they cover a number of topics that people across the nation have asked to hear about. For foundational areas of the National Action Plan are the topics of discussion, and we hope that you'll participate in those as well. Next slide, please. This again is the website and the listserv that I mentioned earlier, and I encourage you all to sign up if you haven't already, and to engage in these discussions. And so, by way of introduction, I think and welcome, I think we're done, and really want to get at the meat of today's webinar. So I'll turn it over to our next speaker, and Jade, I think that's you.
Great. Good afternoon, everyone. Thank you, Dr. Valdez and Helen, for your comments. And I'd like to start out by saying thank you to those who entered their thoughts into the chat. There will be multiple opportunities to do that through the remainder of the call, and we definitely want to encourage to hear from you, either via chat or vocally by raising your hand. I'm excited to share at a very high level some of the National Action Alliance summary of requests for information of the comments that we received. Next slide, please. We were very fortunate to have about 99 comments received from a broad range of stakeholders, including healthcare systems and providers, membership organizations such as associations and societies, colleges and universities, nonprofit organizations, and many individuals, patients, and families. Next slide. We issued six questions in total, and I'll very briefly highlight those and some of the key findings that we had. I'd like to say that the information that we received was so rich. There's no way that we could share with you all that we have learned, but you will see it show up in how the Action Alliance is being created. So more to come on that. But the first question was, what can HHS bring to the Action Alliance in terms of coordination, alignment, tools, training, and other non-financial resources? And particularly in how we assist healthcare delivery systems and others in advancing patient and healthcare worker safety. Next slide, please. And we heard that what would be very helpful is, and multiple times, in fact, that we provide a clear vision, mission, strategic goals, priorities, that we discuss governance and the structure and roles and expectations for the Alliance, that it is helpful when we convene stakeholders, providing resources and tools such as training. I'll be very honest with you. I was with all of the training that occurs and multiple programs that are focused on training. I think that there was new training requests that were heard, such as for traveling nurses and how to establish, to walk into any organization, any hospital, and immediately be able to get to work. Coordinating across federal departments and agencies, and then providing a central repository of lessons learned, best practices, and harm events. And I will let you know that we are in the background working to get some of these requests into place, and so that we'll have more to share at the launch. Next slide, please. The second question was, how can the Voluntary Action Alliance most effectively support healthcare delivery systems and other stakeholders in advancing patient and workforce safety? And are there specific priorities or different types of systems or settings of care that which we should focus? And what stakeholders should be part of the Action Alliance to make it most effective? Next slide. And what we heard is that there's a real need for resources and community educational tools across the continuum of care. If there was one key message that came through very clear, is that we should not only focus on hospitals, but really look at all aspects of where care is received, whether it's a skilled nursing facility or home care or others. And that cultivating best practices, getting very tight on what works, and then spreading those practices very widely. On a couple of different occasions, it was important that to some of our respondents to understand the budgetary and financial elements of advancement to patient care. And you'll see this particularly as we talk about workforce safety and how to address violence in healthcare settings. And there were some really wonderful comments about the additional cost for security training, for how we address violence that previously we had not focused on or needed to focus on. Next slide, please. The third question are, what are other national patient and workforce safety initiatives that we should be aware of and how to best coordinate? Next slide, please. And I would just say thank you to everyone who responded, because there is a lot of work occurring. And so part of co-developing this work will be to find the sweet spot where we can make the most difference in the shortest amount of time that will benefit the most people. And these are just some of the organizations that have an initiative or have key work that's occurring. And I won't go through each of those. Next slide, please. The fourth question is, how can the Action Alliance best support healthcare systems in advancing healthcare equity? And as you know, this is a priority of both the president and Secretary Becerra. Next slide, please. And we received really robust feedback from you all, including asking, how to define and develop an equity-based scope of work and establish target goals. There was a lot of discussion about the formation of an aim, which we know very often drives improvement. There was discussion about training a diverse healthcare workforce, standardizing and collecting data to help identify healthcare disparities more readily, supporting efforts to share best practices to advance health equity, maximizing full utilization of healthcare professionals such as pharmacists and nurses, and investing in the public health infrastructure and community health programs, amongst many others. Next slide, please. And question 5, are there specific practices or innovations that healthcare delivery system or others have implemented during or post-pandemic, including practices focused on populations that experience healthcare disparities and individuals living in rural communities that others could benefit from learning about? Next slide. And many of you provided great information about how your response to the pandemic has reshaped the work that you do. And one example that I think no one will be surprised by is telehealth programs. And some of the programs that were mentioned, how telehealth is being used, of course, with COVID, postpartum care and hypertension management, mental health management, coordinated substance abuse disorder. And we're only beginning to tap the surface of how telehealth can expand our healthcare delivery system. We received some really wonderful information about standardized de-escalation training and how folks during the pandemic had provided training for security professionals and a 3-tiered workplace violence program. Also, the institution of new health equity standards based on the experience that we observed during COVID. Next slide, please. And our final question, or what are the main challenges that healthcare delivery systems and others are facing? Next slide. And this is really where we received the most feedback. Was so very helpful to our understanding about how to develop the National Action Alliance. But I think it's important to quickly touch on these physical and psychological, workforce safety, including burnout and mental health. Workplace violence and verbal abuse was at the very highest of the comments that we received. Infection control and prevention, a call for a focus on ergonomic safety or safety all across the board and different settings. Staffing turnover and retention, which I don't think anyone on this call will be surprised by. Staffing reimbursement rates, and then again you'll see that training showed up again. Next slide. And I'm going to skip this one. Next slide, in the interest of time. And again, in the interest of time, I would like to ask you to include in the chat, what message would you like to add to what you have just heard, recognizing that this is a very high level summary, but we would like to hear from you directly to make sure that we capture everything. Importantly, later this week, we will be publishing on the AHRQ Action Alliance website the summary of the RFI, which will provide more details to accompany this presentation. So I thank you for your time and again for taking the time to respond to our request for information. And with that said, I'll turn things over to Erin Grace. Next slide, please. Oh, I'm sorry, no, next slide. Okay, thank you.
So I was just looking at the chat from the question that Jade just asked in terms of what message would you like to add to what you just heard from her. I see one, why is it so difficult to reach anyone at the CDC?
We'll take that back.
Yeah, we can come back to that one. So thank you for that. So good afternoon, everyone. And I think it's still good morning for some of you. Oops, put on my camera. There we go. Thank you. I am Erin Grace, and I'm the acting director for our Center for Quality Improvement and Patient Safety. Next slide, please. I'd like to spend a few minutes talking about the National Action Plan to Advance Patient Safety. AHRQ co-chaired the National Steering Committee for Patient Safety, referred to as the NSC, which was convened by IHI and created a National Action Plan. The NSC included 27 organizations, which, when brought together, included representatives with a shared interest in energizing patient safety efforts. The NSC's intent was to provide a clearer, more unified vision in terms of what is necessary to make advances in patient safety, to reduce harm in healthcare across the continuum of care for patients and for the healthcare workforce. Next slide, please. 4 foundational areas were identified in the National Action Plan as a necessary foundation to advance patient safety. Each of these areas and interdependencies across these areas must be present for broader rather than incremental improvements in patient safety. Next slide, please. In May of 2022, the NSC issued a declaration to advance patient safety, calling on all healthcare leaders to take steps to implement the National Action Plan, starting with reviewing and understanding the 17 recommendations and tactics of the National Action Plan, identifying a senior sponsor and team to deploy the self-assessment tool, and then enact strategies, tactics, and measurement and improvement plans with support from the Implementation Resource Guide. An important next step for organizations to consider is to deploy a self-assessment tool for your organization. Our next 2 presenters share their experience with the importance of self-assessment. While there are other means of self-assessment, certainly to advance patient safety, their 2 health systems used the self-assessment tool associated with the National Action Plan that addresses self-assessment in each of the 4 foundational areas. I will now turn it over to Kelly Randall, who would describe how Ascension Health has implemented the National Action Plan self-assessment tool and what they have learned. Next slide, please. Kelly.
Thank you so much, Erin. It's a pleasure to be here with you all today and describe a little bit briefly about Ascension's journey over the past several months with the National Action Plan self-assessment tool. Next slide. Ascension is a large healthcare organization with about 140 hospitals and over 2,600 sites of care spread across 19 states and the District of Columbia here in the US. We are organized geographically into what we call ministry markets, given that we are a Catholic healthcare organization. And this is important for our structures. We decided how we were going to take on completing the self-assessment. Next slide for me, please. So as we were thinking about the assessment, there is no right or wrong way to complete the assessment within your organization. We determined that we would complete the assessment with each of our geographically defined ministry markets. So for us, there are 12. While we did the assessment, we convened a meeting. It was about 3 hours in length, quite honestly, of our market and our hospital leaders. So we made sure that in that time designated, we had representation from our C-suite, from quality and safety, from risk management, associate health, physical safety and our patient family experience colleagues, both at the ambulatory level, the hospital level, and then our ministry market level from a leadership perspective, brought a large, diverse group of leaders to the table to embark upon the conversation together. Next slide, please. So I'm gonna talk just a bit about the logistics of how we actually walked through the self-assessment. For us, we just completed the self-assessment process across our 12 ministry markets and are in that transition period and looking at strategy and improvement. So from a logistical perspective, given that we are a Catholic healthcare organization, we start each of our meetings with a reflection or a prayer, and we wanted this time together to be no different. So we started with a reflection around our hopes and our shared concerns about the current state of patient safety, both in our organizations as well as across the United States and our industry. What this does was allowed us to come together as a leadership team and focus on where we felt really good and really hopeful about the things that we had going on, yet where we had concerns about opportunities that are left for us to address. Towards the end of the session, we did circle back to that reflection and exercise at the beginning, and I'll talk about how we did that in just a second. We did establish group rules together as a leadership team at the table. The very first group rule and purpose is all teach, all learn. So this time together was a time for us to be vulnerable with each other, be honest, and be transparent about where we were in relation to the scoring matrix and the self-assessment. I joke with my leaders and said, including myself, we are checking our ego at the door. This is not about us looking good and scoring at the top of the matrix. This is about us identifying and learning where we have opportunities based on the action plan. We did level set a bit with some definitions. So there are things within the national or in the self-assessment that may be specific or different in each organization. For example, one of the questions talks about senior leaders. So we defined in our organization what we said senior leaders were. We are talking about director level and above. We also defined things like level setting around when it asks about harm. This is what we mean in our organization, because we look at harm in many different ways across the nation. When it says sufficient, this is what we want to think about and how we're comparing ourselves to that scoring matrix. We had 2 facilitators that were present for each of the self-assessment sessions that we conducted. One facilitator was very focused on the logistics, right? So having the self-assessment on the screen, helping walk us through the difference in the scoring matrix, scores 1 versus score 4. And recording the comments and the discussions and the actual score that we provided for ourselves or we came to consensus on. Very logistical in focus. The second facilitator was more managing the group and the conversation. So that person was standing back, asking probing questions, being challenging to the group, maybe to think differently or think deeper, think broader, and then helping the group come to consensus. So I really see this facilitator, or we in Ascension saw this facilitator kind of as that manager of the group dynamic. Who is it in the room who is not speaking up? How can we encourage or give that person permission to say what they may, what their perspective may be related to that score? How can that facilitator help generate and escalate the level of psychological safety in the room? At the conclusion of our time together, after we had completed the score, as I said before, we circled back to that hopes and fears or hopes and shared concerns reflection that we did at the beginning. And we asked the group, in this, as you assessed and as we talked about where our opportunities were and the things that we were doing really well across our organizations, did it reinforce the hopes that you voiced? And did it help alleviate or mitigate some of the concerns that you shared with us? By and large, what we found is many of the concerns that were shared by our leaders were addressed in some way, form, or fashion through the self-assessment and the recommendations that go along with those in the National Action Plan, and actually were able to give us some hope that those shared concerns will be resolved as we strategize and implement many of the recommendations from the National Action Plan. And then finally, at the end, we talked about the need for local action and improvement so that we can continue on our journey and ascension, towards zero harm. Next slide. So as we reflect in Ascension on how we did with the self-assessment, where we scored, what our next steps are, and as we begin to plan many of the improvements or enhance many of the improvements that we have in our strategic plan, here are a few reflections that we had. First, leadership must establish safety as the highest priority. We heard this from both of our opening speakers today. We have to learn together how to provide safer care. And that really does start at the top. There's a lot of competing priorities in healthcare today. We can't let safety move down in that priority. Second, structure, process, and outcome are absolutely important. You will see a lot in the self-assessment and the National Action Plan around structure, process, and outcome in each of the 4 foundational areas. But don't forget about accountability and sustainability. If we implement improvements in our SPO, but we don't ensure that we have mechanisms for accountability and sustainability to those improvements, we're going to continue the roller coaster cycle of our up and downs in the patient safety space. And then I would say compare your structure side by side with the action plan and recommendations, right? So integrate your findings from the self-assessment and the improvements that you're going to make based on the recommendations in the National Action Plan into your strategic plan and the initiatives that you have going on. Don't let it be a different or separate initiative. Be agile with it, and that integration, like I said, is key. So if you'll go to the next slide for me, please, a little bit about how we're doing this at Ascension. This graphic is designed to really show how we're connecting the dots. We have our focused improvement teams around surgical never events, falls, pressure injuries, all of the harms that I'm sure each of you are focused on as well. But laid over the top of that is our focus on leadership, safety, culture, and our learning system, which we tagline as all teach, all learn in Ascension. Without this overlay and focus, it doesn't matter what we do in each of these vertical lines, we'll never get to that sustainability of zero. And so working on both of these together in this basket weave is the path forward. So thank you so much for listening a little bit about our Ascension journey. We're looking forward to our full analysis of our self-assessment data and moving into that next phase of understanding how we can further improve our structures within Ascension. And with that, I am going to turn it over to our next speaker.
Very good. Well, good morning from California. I'm Helen Macfie, and I am the, hold on a second, I'm just going to get something off my screen there. See if I can get, there we go. I am an executive in residence actually at Memorial Care. So if you head out to California, land at LAX and head south, you'll find us. We have 4 hospitals. We're smaller than this, but we do have 230 sites of care. We've sort of intentionally shed heads in beds, if you know that term, and really focused on ambulatory presence. So we have a lot of ambulatory facilities that we partner with, so surgery centers, imaging, dialysis, physical therapy. We recently added dental. You know, the window to the body is through the mouth, apparently, and your oral health is very important to your physical health. So, and I get to be, I've actually, until last June, I was our Chief Transformation Officer for the whole health system. I'm now the Chief Operating Officer sitting up here at 2 of our larger hospitals up in Long Beach, a very diverse city, which we'll come back to when we talk about equity. So next slide. So Kelly and I have found each other through this process and working with Patricia McGaffigan, who's also on this call. really thinking about how to think deeply. As Kelly said, we can all do this differently, but the important thing is to do it. And so really taking that action plan and making it actually action. So on the next slide. So just a quick story. I was in this role across the health system of transformation. And of course, there was a thing called COVID. I was actually also incident commander for the health system with that. And coming out of COVID, as many of you may have experienced, really our team was overwhelmed and besieged. And not only that, but patient complexity, especially for patients that we're seeing in the hospital, is ever rising. So I'm not sure if I've seen that in other states, but we certainly are out here. The case mix is up, the severity of illness is up, the risk of mortality is up from all cause. And at the time I had the great pleasure of being an IHI fellow, Institute for Healthcare Improvement in 2022. And Patricia McGaffigan came as one of our early speakers, actually in January, I want to say, or February of 22. And she talked about the National Action Plan. And I had actually been part of the learning system development plank of that work. And so it was terrific to see it coming out. And we really thought about this, that this would be a great way to re-energize the team. So this all is rooted in Helen Haskell's, plea that we need to really focus on improving safety for our patients. It's also about making it a priority, and then also making it our teams that are doing the hard work on the front lines really sort of give them a path forward. And we didn't have a tool at the time, actually, through what was published. So we actually just took what was published at the time and then added it. So I'm going to be very transparent today and show you exactly what we got. So if you go to the next slide. So this is for me and all my friends on this call. But basically, this is an example of what's actually, when you get down to the granular details. So under culture, leadership, and governance, there's an element called safety goals. There's a lot of other elements. And you can see what Kelly was saying, how you score yourself. Basically, it's iterative, from a 1 to a 2, 2 to a 3, 3 to a 4. New words show up that are very important. And actually, Kelly and I are on a work group that's currently helping to make these even more specific or provide examples. The thing that we did is, as we sent it out, so the same thing, we agreed it would be senior leaders and quality leaders and the like. One of the things we realized is that we didn't do it as a group. We actually sent it out so people did it independently. And we got a range of scores, which was, I think, very important, not just to average them, but actually to look at the distribution, because my 4 might be your 2. And then why is it different? And then we actually got back together for a 3-hour retreat, a similar length of time, and discussed why. And then we added a row for, well, what do we want to do about this? In this case, for safety goals, I saw a note in the chat about infections being so important. Absolutely, those are one of our goals. And we have those. We did identify that the words that matter to get to a 4 are making sure we have a senior sponsor for every single one of our bold goals for quality and safety, which we actually then did for the following strategic plan year. So if you go to the next slide, I think our big takeaways, and I'm going to show you the results and a few quick examples of how we've done this. This, as Kelly said, it's absolutely not about trying to make yourself look good for some score. But really to be very honest and reflective, and to understand how we can improve. It's about finding the pearls, and then it's also about coming into collaboratives like this, where we can share across the US and around the globe, what's actually working, and then leveraging the exercise to kind of think more deeply, why, like a very good root cause analysis. And then even where we are good, we can improve further, and it's a journey. So if you go to the next slide, this is going to be available in your slides, so I know you won't be able to read it on screen per se, but one of the things that we did do is we color-coded the outcomes. So if it was a 3.5 or above, it was a dark green. 3 to 3.5, on average, it was a light green, and you can kind of follow the rest. And it allowed us to really think deeply about, well, where are we doing okay? Where's our low-hanging fruit? Where's something that seems really, really complicated, and how can we do that? So just to show you that I think that actually was a helpful way of doing it. If you go to the next slide, this is just the end. These are all the different rows in that section. And then you end up with a score for the overall section. And one of the things that we had thought was an opportunity for us was to really think about our safety culture and resilience results. And so we had put that into the action plan. to make sure that people do feel safe to speak up on our staff and do believe in a fair and just culture. So if you go to the next slide, just shows you an example. Now, if you know this vendor, you'll be able to pick that out, but I scrubbed it from these slides. But basically, as an organization here, it's on a 0 to 5 scale. We're scoring about a 4, which is pretty good, 3.97. We're a little bit above just a titch above the national average for this particular database, and we improved since the last time we did the survey. You'll notice right away where we have opportunity to improve is in resources and teamwork. Situationally, this was taken right after coming after our Omicron surge, so that kind of makes sense. And then on the right, you'll see we also ask questions about resilience and people's ability to kind of ride the wave of all of this opportunity we've had over the last 3 years to really think differently, and that's worked pretty well. This gives us data down to the front lines, to each unit and department, so we can really work with managers to improve. On the next slide, what we really loved about the overall handbook or toolkit that Patricia and others put together is at the end of each one, there's sort of examples. Well, how can you move from a 1 to a 2, 2 to a 3, that kind of thing, and examples of what you might do. Those are going to be different by entity, by department, all of that. So if you go to the next section, it's actually our lowest scoring section. Sorry, Helen H. But this is around the next slide, please, for patient and family engagement. And you can see we had more orange and yellow. And this really, as we talked about it as a group, it's because during the pandemic, we set everybody home. So our patient family advisory committees were not as active during this period. We were keeping everybody safe, but we were also keeping them away. And so the obvious solution there is really to bring back our PFACs. They were on Zoom, but now we're in person. And in California, now we can even do it without masks so people feel safe, as long as you're not in patient care. And that's been great. Or when we do lean events, redesign events, making sure we have patient and family voices at the table. So just an example of some of the things that we've done. But in this section, if you go to the next slide, and then the next one after that, this section really talks about equity. And we were just mentioning earlier, Long Beach, where I'm sitting today, is a melting pot of zip codes and ethnicities and race and different, how people identify. And so we have lots of opportunity here. And one of the things I was chairing, and now my succession plan is chairing, is our diversity, equity, and inclusion focus for memorial care. And we've captioned it DEI for our workforce, DEI for our patients, DEI for our communities. And this you can see is our visibility board of how we're tracking. And one of the things that we realized along the way is that we've done some very good work in segmenting our data by patient type. We've improved the care of obstetric patients, for example, to where people who identify as Black and African American for a certain type of C-section, now exactly the same as the rest of the population. But we have more to do around sensitizing our workforce to unconscious bias. And if you go to the next slide, just an example of how this conversation really helps, because as we looked at the plan for safety and our gap analysis, we really need to go out and provide workshops for all of our managers. We started with them, actually got to, I think this might say, or used to say 95%, but now we're at 100%. But we've also now released micro-learnings for all of our staff and really enlarging the conversation around equity. So if you skip forward 3 more slides, there's a couple in there about workforce safety, keeping our staff safe so they can take safe care of our patients. But this is actually an example of a roadmap we made to really help us understand how we might approach workforce safety. And that's a whole nother talk probably for another day. But we've actually reduced our workforce safety incidents by 25% after setting a bold goal to do that through a number of interventions. And now we're going for the next 25% reduction. And then finally, the learning system, and that was the one I got to help write. If you go to the next slide, this is one that really helps us think through how do you set up and learn internally as well as externally. So sessions like this, a lot of work with the Institute for Healthcare Improvement has been great. I'll say one thing here. If you don't score well on patient engagement in the second domain, you can't score well here either, because we do need to bring that back into the forefront. So, but overall, we did pretty well on this one. And so if you go 2 more slides forward, one of the things I wanted to mention then is, well, how does it all matter? Like, how does it go back to the data that we looked at the very beginning of the call? We have bold goals that these are our inpatient bold goals. There was an original Partnership for Patients focus that looked at different kinds of harms that an inpatient, when you're admitted to a bed, that we also have them now for ambulatory. But this is like data over time. And we've been able to reduce our harm across the board from close to 4.5% of admissions down to around 0.5%. And it went up a little bit during COVID, but it's come back down. And of course, there's still the gap below that and zero. And I think that's what we're all about today. But creating this construct to the National Action Plan really has helped. So if you go to the next slide, and I'll wrap up. Where we are now is we've created that action plan. We actually are reconvening our team to take a look at what we've accomplished and where to go next. We've discussed it with our Memorial Care Board quality close and committee. We could close the books on quality every quarter. So like one would do for finance. We're activating all these things. People feel really good about the work. And then we've been obviously discussing our progress with our teams here. And finally, last slide for me, I just think this is actually the outcome. I love my job. Using something like this to really create esprit de corps, bring back joy at work. And I think it's just another thing that we should all be paying attention. So let me just turn it back to the team that's leading us today. And thank you so much for listening to Kelly and myself.
Great. Thank you so much, Kelly and Helen. This was 2 fantastic presentations, just chock full of what I think are great key takeaways. And we really want to hear from folks what you are hearing. You know, at the top of the hour, you heard from Dr. Valdez that it is HHS's plan to launch Action Alliance with a defined goal sometime in the fall of this year. And so now the way that we are viewing the time between now and when we officially launch is really a point of assessment and reflection. You know, given where we are as a country, taking a look at our individual data, and this tool is just one of several assessment tools that you might consider as you do your own reflection. So we've posted into the chat what is your number 1 key takeaway from what you've heard today, and would love to hear from some folks. If you would like to raise your hand and be heard, we would love to hear your voice, and our team will work to unmute you. But we're also love to hear from you in the chat. In the meantime, I wonder if I might turn to Helen Haskell, who is always so very insightful. Helen, would you mind sharing some of your key takeaways from today?
You know, these are really terrific initiatives. I really like the fact that they're so comprehensive. I think that's what it takes for patient safety. You have so many threads to intertwine. And what I particularly like, of course, is the concept of the learning system. I think that is something that even in the National Action Plan sort of gets overlooked. That's where everything has to go. And the point of the learning system, in my mind, is, you know, to get back to that basic interaction between patients and providers. And I think to really learn, you've got to have the patient voice, particularly in the learning system, because you don't know if you're asking the right questions if you don't have patients providing input and telling you what they're seeing. So those are just a few of my thoughts. I think these are great, and I hope we see many more of them.
Thank you so much, Helen. I see that there's a comment, Beth Ullum, she's saying, great work for those organizations who are not getting safety resourced in their organization. Can you give some advice to organizations as to how to get greater support for resourcing for safety work as an integrated operational commitment? Helen, Kelly, would you like to respond to that?
I can start. So I think it is, so it kind of helped in my prior role. I was also over strategic planning, so I was able to write into the plan. But I think that is the first step, is to make it strategic. In our vernacular, we use bold goals, like they're goals and they're really bold. So not just a 5% reduction, but a 50% reduction or a 75 or get to 0. And I think that's been very helpful. And then that's the first thing. The second is to make it visible and to make the data uncomfortable. So if you look at the data and you make it so squished that it looks like we're average around here, that sort of tells a different story than if you really demark your data and show it so that it shows all the opportunity that's left. So showing the numbers of people that are harmed is one way to do that. Really, again, looking at how you visualize data and tell the rest of the story. And then the third, I think, going back to what Helen Haskell said, is creating a sort of a relentless pursuit of safety so that people, they can't really avoid it. So we have a series of best practice teams, and each one of them has goals around equity and drilling down into their actual segmenting their data this year. So it's all sort of baked in. So part of it, I think, is probably goes up way upline to top leadership to for their responsibility, and then organizations such as AHRQ and others, IHI, can make it so that people do need to pay attention to this, because it can be written into standards. And I don't want to over-regulate it, because that kind of can be a problem too, but to make it so that each organization out there is really paying attention to this. I think hospitals have done a reasonably good job with that. I think for the other areas where this action plan may apply, there's more work to do, skilled nursing facilities, et cetera, who may need more help.
Thank you, Helen. Kelly, any thoughts you'd like to add?
Sure, I just put one in the chat. I would echo Helen's thoughts, right? Use the data, get comfortable talking about the uncomfortable. It's the stories that connect and create the platform for the resources that we need to work towards eliminating the harm, and then connect it to other areas of operations, right? Had a colleague of mine say this morning, a safe environment is better for the patient experience. It's better for the provider experience. It's better for us financially as an organization. And it's for us, it is our mission. And so when we connect it to all of those areas of operation, it makes it everybody's accountability and everybody's responsibility, which helps generate those additional resources.
Great, thank you so much. Those are all fantastic comments. Let me just do a quick check-in. Erin, do we have anyone who has raised their hand that would like to unmute themselves?
I am not seeing anybody.
And that is totally fine. I do have another comment from Laura Cooley, who's saying that she has many takeaways from today. She says, due to my role with the Journal of Patient Experience, I'm interested in how we can better engage patients and families in our safety improvement efforts. I'd like to further explore the direct connections between patient experience and safety outcomes. And I'll just say we can certainly help you with that at AHRQ, and we have a team of experts in this particular subject. But Helen, or Kelly, would you like to provide any comments about that?
I was just thinking of one thing. So one of, as we mentioned, we've been doing a lot of work segmenting our data by how people identify. And so one of the first things we did is we looked at people who died from sepsis, a severe bloodstream infection in the hospital. And as we looked at it, the original kind of data that we found showed that the mortality rate for people who identify as Black or African American was significantly higher. And we're like, whoa, is that us? Or, where is it coming from? We actually then we were able to segment our data and look at door to antibiotics, which is, obviously you want to treat sepsis with antibiotics, door to fluids, door to what have you. Time matters in sepsis recovery and saving lives. And it turned out they were all the same, which then gets you to how do people think about going to the ER? And as we looked at that and then we married it up to our patient experience data, there we did see a difference in how people rate our emergency department by race and ethnicity. And so that kind of gets you into, well, then how can we go further upstream and start working with our communities to make it really safe to come to our emergency department, build trust back in the health system. So these are not easy, not all of them are easy things to fix, but once you kind of turn your glasses onto these opportunities and you see with a vision, then I think it sort of helps shape your patient experience focus.
Thank you, Helen. And I'm actually going to give Helen Haskell the last word of the day, since we are at the top of the hour. Helen, would you like to say final closing comment?
Well, I would just say that is an excellent use of data, Helen, and I'm really pleased to hear it. I think that the patient experience really is the key to patient safety. If patients feel safe, they can tell you what goes wrong. So I hope that you will all, if you, there are many lessons from this webinar, but I hope you take to heart the one of including patients in all aspects of your enterprise, and especially patient data, what patients write and what patients say about their experience. Thank you.
Great, thank you, Helen. We'd like to close today by just saying thank you. We know we didn't get to all of the comments, and I think we finally had somebody raise their hand. Please join us again for the next webinar, which will be June 27th. The CDC will be hosting this call. We are working across HHS to bring the summer webinar series to you, and that will be addressing violence in the workplace. We would also appreciate it if you would share this information. All of today's materials will be available on the Action Alliance website. Just Google at the National Patient Safety Action Alliance. Thank you and have a good afternoon.